Good evening, delegates. Good evening, Dr. Ranjana Joshi as speaker. I welcome you all to today's session. So before starting the session, I would like to give a brief introduction regarding our Shield Connect page first. So this is our Shield Connect page, which is a knowledge information, medical information page, which is generally specified on gynecology and pediatric information. And there are many blogs here which were written by many doctors all over the India. You can find those blogs here, and whatever the webinars which we are doing, the current webinars, the upcoming webinars information you can find here, and the different newsletters, awareness, and you can find here. I would like to introduce our dear speaker, Dr. Ranjana Joshi. She is an MBBS MD obstetric and gynecologist, laparoscopic and infertility specialist, senior consultant, Jamshedpur, President, Jamshedpur Obstetrics and Gynecological Society, special interest in gynecology and gynec oncology, high-risk pregnancies, minimal invasive surgeries and robotic surgeries. And the topic is dysmenorrhea. I welcome you, ma'am, and I hand over this session to you.
Thank you so much. I'll just, I think without wasting much time, thank you for giving me an opportunity to speak today. And it is a great pleasure and honor. And I'll now like to begin. I'll share my screen. Is the screen visible?
It is visible.
Okay, we shall begin.
Yes, ma'am.
Am I audible properly?
Yes, ma'am, you are audible.
Okay. Welcome to everyone for today's session on dysmenorrhea and its management. This is one of the most important problems of any woman in the reproductive age. Just 1 minute, my screen is, I'm just closing once more.
Yeah.
No, it's working. Okay. What do I show? Yeah. What is menstruation and menstrual cycle? Menstruation is the monthly shedding of the lining of the uterus. It is also known by the terms menses, menstrual period, or period. This cycle is part of a reproductive system and body. Here, the body is prepared for egg production and a possible pregnancy. When this does not occur, then the menstruation occurs. An average cycle is around 28 days. However, a cycle can range from 21 to 35 days. Now the phases of the menstrual cycle. Here, as we can see, the FSH and LH values, right? FSH values are increased in the beginning of the proliferative phase and also near ovulation. Whereas the LH rises, or there is an LH surge in the pre-ovulatory phase. Events in the ovary will show at the same time, where multiple follicles start developing in the proliferative phase. And near the ovulation, we can see a single mature follicle develops. This ruptures. When this rupture and it is released, it is called ovulation. And when there is no pregnancy, it results in formation. The remaining part of the ovary forms a corpus luteum, ending in a corpus albicans. Same thing in during the early menstrual cycle. Let us have a look at the ovarian hormones. As you can see, in the proliferative phase, the estrogen levels are low. It is just in the pre-ovulatory phase that there is a peak. And again, it falls after ovulation and remains and forms a plateau. Whereas the progesterone remains low throughout. After ovulation, the progesterone values go up and they continue to remain high. When there is no pregnancy, the levels fall and it results in menstruation. Lastly, you can see how the endometrial lining is preparing for the pregnancy. So you can see the endometrium becomes thick, the blood vessels become engorged, they are fully prepared to receive the pregnancy. When this doesn't occur, the shedding of the endometrium occurs in the form of menstruation. Now, what is dysmenorrhea? Dysmenorrhea is originally a Greek word. This is defined as painful menstrual cramps of uterine origin, and it is the most common gynecological condition among women of the reproductive age. It basically refers to pain during menstruation severe enough to prevent daily activities and to require taking medicines. What sort of pain is it? There is lower abdominal pain, back pain, pain with cramps, and some leg cramps. The onset is usually in adolescence. It occurs either from the first menstrual cycle or a few months after the first cycle. This pain has a very clear and predictable temporal pattern. It begins just before or at the time of menstruation, and it is most severe during the first or second day of menstruation. It usually lasts from 48 to 72 hours. What are the additional symptoms? Nausea. Along with this pain, patient also complains of nausea, vomiting, diarrhea, constipation, headache, dizziness, fatigue. Sometimes complains of feeling bloated, insomnia, breast tenderness, most importantly, mood changes. And as a result of dysmenorrhea, what is the impact? There is absenteeism at school, at workplace. There is less focus on studies and work. There is reduced sleep quality, physical activity. Once again, poor mood, anxiety, stress. Basically, it affects the quality of life and performance in daily life activities in women. The rates of absenteeism in these women ranges from 34 to 50%, as high as this percentage, losing 1 to 2 working days per month. This amounts to an annual loss of approximately 600 million working hours, or up to 2 billion annually in the USA. Prevalence, it varies between 45 to 95% of menstruating women. Severe primary dysmenorrhea is estimated to affect as high as 25% of women. As such, dysmenorrhea appears to be the most common gynecological disorder in women, irrespective of nationality and age, and hence it has to be tackled and improve the quality of a woman's life. Now, there are two types of dysmenorrhea: primary dysmenorrhea and secondary. Primary dysmenorrhea means that there is no underlying pathology, whereas in secondary dysmenorrhea, it is the period that signals a reproductive tract disorder, pathological cause, such as uterine fibroid, PID, endometriosis, infection, tumors, or polyps in the pelvic cavity. Classically, we have the primary dysmenorrhea. begins in the adolescent age and it continues mostly throughout life. The exact cause is not completely understood, and it possibly includes multiple factors with unexplained mechanisms. First of all, forceful excessive uterine contractility. It has been seen that during menstruation, women without pain, the uterine pressure is minimal, hardly 10 millimeter mercury, whereas it is elevated in women with pain up to more than 120 millimeter mercury. So you can see the difference. There is increased number of contractions. They per 10 minutes, maybe more than 4 or 5, and non-rhythmic uterine contractions in women with pain. Second factor is excessive synthesis of prostaglandins. And third is disturbances or decrease in the uterine blood supply. If the uterine blood supply is reduced during this pain, then there is the decreased blood supply causes anoxia and resulting in pain. So let us focus on the prostaglandins, which is the most common factor in dysmenorrhea. Prostaglandins are lipid compounds. They are present in the cell membranes. They are produced from arachidonic acid by the enzyme phospholipase A2. Prostaglandins can cause uterine contractions, and hence they play a major role in the dysmenorrhea. Excessive prostaglandins concentration is seen just before menstruation. Prostaglandins, how do they cause dysmenorrhea? They cause abnormal or forceful, number one, they cause abnormal or forceful contractile activity of the uterus, narrowing of the blood vessels supplying the uterus, which leads to hypoxia of the uterus, and increased sensitivity of the nerve endings. So how do we measure the period pain and other symptoms? There is a pain scale which begins from 0 to where it is almost no pain to the very high pain or worse pain, that is 10. So many of these questionnaires are based on this pain scale. The primary dysmenorrhea, there was a study done from 1,000 healthy females between the age 11 to 28 years. And this data was collected by these questionnaires. And yes, menstrual pain was found to be in 70% of these patients. And the intensity was quite high, as you can see, 47%. So this is, as a result, you can see how significant this study, this shows dysmenorrhea is in a woman's life. Management was being done in various ways. Either these girls stay in bed, or some of them show to the doctor, or hot bath, or a heating pad, or they have some food fads, some exercise. But let us accept it that it has to be treated properly with some medicines. Pathophysiology. Women with dysmenorrhea have, as I mentioned earlier, they have excess of prostaglandins, and these prostaglandins, they cause forced uterine contractions, and this reduces blood supply, and this ischemia results in further pain. How do we diagnose? Very simple. We get a simple medical history where the patient will tell that the pain begins with the onset of the periods and can last for 48 to 72 hours. Physical examination will show no abnormality whatsoever. Ultrasound will also show no abnormality. This is primary dysmenorrhea. Now, how do we treat them? The first line of therapy has till now been mefenamic acid or the NSAID. That is, we have other NSAIDs also, but mefenamic acid is the most commonly prescribed drug. Second line of treatment are the OC pills. Mechanism of action of the mefenamic acid is along the arachidonic acid pathway. But what are the drawbacks of the existing NSAIDs and OC pills? We have the GI side effects, well known: nausea, vomiting, diarrhea, stomach aches, serious side effects of stomach ulcers and GI bleeding. Other side effects are headaches, drowsiness, dizziness, allergic reactions. NSAIDs are contraindicated in renal insufficiency, peptic ulcer disease, a patient with gastritis or GI bleeding, overall failure rate of 20 to 25%. Long-term use is discouraged, obviously. OC pills are not approved for dysmenorrhea, but they are still being used, especially when NSAIDs are not so effective. But we all know that OC pills have the side effect of thromboembolism. There is always a risk of it. Other approaches for dysmenorrhea, as I mentioned earlier, we use heating pads. Patients just goes and wants to rest. Some acupuncture, acupressure is there, meditation, ginger root, turmeric extract, pineapple extract, salt water, calcium and vitamin D3 supplementation. All these are the various methods which have been tried. And now we come, for the first time, Shield has launched Dysmenorrhea, which is a fennel extract, rosemary leaf extract, curcumin extract, and pineapple extract tablets. Now let us see what this is. What's so special? Dysmenorrheic action is antispasmodic, anti-inflammatory, and analgesic. It has all these three effects. So as I just mentioned, pineapple extract. So where does this bromelain comes from? It comes from pineapple juice and pineapple stems. And how does bromelain act? It has an antispasmodic effect by inhibiting arachidonic acid and thromboxane A2, PGF2, and PGE2. Analgesic effect is decreased pain due to and decreases forceful contractions. Anti-inflammatory effect is by modulation of the TNF and IL. Both of them are interleukins. So there were 39 female students aged between 15 to 17 years were enrolled in a study, and they received pineapple juice. And another group which received a placebo. As you can see, before treatment, the pain score was 5.2, whereas after treatment, the pain score was around 2.25. The other product inside in this the drug is the rosemary extract or the ursolic acid. The this active constituent, it has an inhibitory action on COX-2, and inhibitors of COX-2 enzyme can reduce the production of prostaglandins. Basically, they are reducing the prostaglandin levels, just like mefenamic acid, and this can result in antispasmodic and analgesic action. This is the mechanism of action. There was a comparison of ursolic acid versus mefenamic acid, where 82 women from the age group of 18 to 25 were enrolled, and they were divided into two groups, ursolic acid and mefenamic acid. So what was the result? Both of them received 250 milligrams each for the first 3 days of menstruation. And now have a look. Ursolic acid was found to be as effective as mefenamic acid. Curcumin. Turmeric is derived from curcuma longa and includes curcuminoids. It is a member of some regional diets in numerous Indian and Asian cultures. So mechanism of action of curcumin, it works by modulating the inflammatory response by regulating the activity of COX-2 once again and INOS, so that this will reduce or even inhibit the uterine contractions. And the mechanism of action of blocking uterine contractions is by reducing the influx of calcium ions into the calcium canal in the uterine epithelial cells. And that is how it has an anti-inflammatory action. And it is frequently used, curcumin is frequently used with bromelain to improve the absorption. So you can see the mechanism of action. Once again, a study was done to see the effect of curcumin on primary dysmenorrhea. In this study, 32 young women with primary dysmenorrhea were enrolled and they were given curcumin drink. So now you can see, once again, the pain was less than 0.0001. The p-value was significantly reduced by curcumin drink. Now we come to the fencone and anethronol. This is the third constituent of dysmenorrhea. This is, as even in the standardly fennel seeds have been used for PMS and cramps. Where does all both of these products come from? The mechanism of action of fennel is similar to diclofenac. This is very, very significant. Fencone as the main constituent component of fennel that inhibits prostaglandin E2 and it reduces uterine contractions. Hence, it is an antispasmodic. Anethole as the main component of fennel has a similar structure to dopamine, which binds to dopamine receptors and decreases the pain. Therefore, it is an analgesic. The anti-inflammatory effects of fennel is due to the inhibition of histamine H1, H2 receptors. So they are antihistaminics for cough and cold. So you can see wonderful effect of the fennel extract. Once again, the mode of action, mechanism of action, fencone acts at the by inhibiting prostaglandin E2. And anethronol, you can see dopamine. So this is the anti-dopamine action of anethole. Effectiveness of fencone versus mefenamic acid. 100% women had pain before starting the treatment. The women received either fencone or mefenamic acid. And now here you see the pain's intensity. We can see 80%. The percentage of women reported no pain after the treatment after using fencone was 80% and mefenamic acid 73%. Hence, we can see fencone is as effective as mefenamic acid. Our study report. So now you can see a multicentric single-arm open-label study was done in which 120 women with moderate to severe dysmorphic pain were enrolled. Dysmenorrhea for 2 consecutive cycles from day 1 to day 3 of menstruation were given, and the dose was twice a day. The results, as you can see, the pain score and the pain duration. The baseline pain score 5.06. There was a significant reduction in pain. Okay. Once again, the pain relief within approximately 32 minutes from 38 to 30. Even in the other menstrual symptoms, like I mentioned earlier, vomiting, nausea, diarrhea, even those symptoms there was a significant reduction in those symptoms also. The best part of the whole thing is that there was no side effect was observed during this study. Now coming to secondary dysmenorrhea, which I had mentioned earlier. This is basically due to an underlying disease of the pelvic organ. Here, classically, we have the patient who has never had any pain during her cycles, and suddenly, after so many years, she starts complaining of pain. So for this, here we can see the causes are both gynecological and non-gynecological causes. So classically, we have endometriosis, congenital anatomic abnormalities, STDs, infections, PID especially, adenomyosis, very, very painful, uterine leiomyomas, and cervical stenosis. The 9 non-gynecological causes are high-tone pelvic floor dysfunction, irritable bowel syndrome, bladder pain syndrome, pelvic adhesions, and IBD. Here we can see the typical endometriotic black spots. I'm sure all of you can see. They are, believe me, the patient suffers terribly in endometriosis, and she really, really needs supportive treatment. So when we evaluate a patient with secondary dysmenorrhea, as I mentioned just now, We have the history is very important. We have several years, patient had no problem and suddenly she's having pain. And we'll have to take a history of any discharge, any fever, vaginal discharge, any IUCD, any IUCD insertion, previous pelvic surgeries. Adenomyosis also causes heavy periods, very painful. Infertility and dyspareunia is also history seen in endometriotic patients. Physical examination, yes, per abdomen and per vaginal examinations will give us a definite hint to the cause. Investigations, we do typically the CBC, cervical and vaginal swabs for culture. Transvaginal ultrasound is definitely the gold standard for this, because this will help us to detect the pelvic masses, uterine fibroids and polyps, pelvic abscess, and adenomyosis. Then, when we start suspecting that there is definitely a problem, laparoscopy is something which will definitely will, especially for endometriosis, it is the gold standard, and it will definitely give us a very good idea of where the problem is, and we can use that even therapy as a therapeutic progress, as an option at the time during laparoscopy. Hysteroscopy also defines the intrauterine pathology, as we can see any endometrial polyps, and we can also take a sample for biopsy. So this is the way we are going to have history, physical examination, ultrasound, and diagnostic laparoscopy. Typical features, just to summarize, primary dysmenorrhea, it begins shortly after menarche, and especially within the first 3 years. Secondary dysmenorrhea is at any time after menarche, usually many years later. Time, it is present during ovulatory cycles and menses only, whereas secondary dysmenorrhea can be also in between the cycles. Age of primary is usually between 15 to younger age group, and whereas secondary is a little on the other side, between 30 to 45 years. Duration is barely up to 8 to 72 hours, whereas secondary dysmenorrhea, it begins prior to periods and may even continue after the periods. The symptoms are typically in primary back and thigh pain, headache, diarrhea, nausea, vomiting, other gynecological symptoms, whereas in secondary dysmenorrhea, patient can also complain of menorrhagia, vaginal discharge, and dyspareunia. Here, I would like to mention about the primary dysmenorrhea. We also can come across with patients having typical like a menstrual headache. I have seen patients suffering with this menstrual headache. So this also I wanted to mention, and it's really very tough for these patients. Pain, the patient in primary dysmenorrhea has lower pelvic or abdominal pain associated with the onset of flow for around 72 hours. And here, once again, can occur at any other time, anytime, even between periods. Primary dysmenorrhea gradually improves over time. And we always tell our patients, don't worry, once you get married or as you become older, it will become better. Whereas secondary dysmenorrhea becomes worse over time. The sexual activities improves in primary dysmenorrhea, but there is no change in secondary. Postpartum period also, a postpartum primary dysmenorrhea improves, but in secondary dysmenorrhea, there is no change. Findings of internal examination, there is no findings, abnormal findings, whereas in secondary dysmenorrhea, we will definitely find a cause. Dysmenorrhea, one mention I must give, that dysmenorrhea should not be confused with premenstrual syndrome, which presents with similar symptoms. Premenstrual syndrome symptoms, they resolve shortly after menstrual flow, has begun, unlike dysmenorrhea, which continues for up to 72 hours. Just a few words, what is PMS or premenstrual syndrome? It is a group of physical, emotional, and behavioral symptoms that occur in second half of the menstrual cycle, and it often interferes with work and day-to-day activities. Here, the period of symptoms are entirely free, starting with the menstruation. Once the menstruation begins, the symptoms disappear. And what are these symptoms? A bloated feeling, weight gain, edema, breast pain, tenderness, hot flushes, headache, pelvic pain, change in bowel habits. And the patient becomes irritable, aggressive, depressed, anxious. But all these symptoms subside once the periods begin. Cause is not known. Various hormonal interactions, vitamin B6 deficiency, all these have been implicated. Some even say psychological. But yes, these symptoms is present. Ovulation and progesterone production are important in this syndrome, and drugs that inhibit ovulation, they relieve the PMS symptoms. So you can see the OCPs here have a very good role. Counseling and reassurance that symptoms are real and it could be treated. Lifestyle, exercise, dietary modifications, exercise 20 to 30 minutes. They will increase the endorphins in the brain and distract the woman from her emotions. Medical, symptomatic for bloating, diuretics can be given, but generally they should be avoided. Antiprostaglandins are for pains. Breast tenderness, we can give bromocriptine. We can give vitamin E capsules. Ovulation suppression, we can use OCPs, danazol, medroxyprogesterone, and primrose oil. So now to summarize, we have this whole management pathway for dysmenorrhea. But let me tell you, the dysmagesic will be a very good alternative for mefenamic acid, and it can always be encouraged. Take-home message, dysmenorrhea is found to be highly prevalent. Findings suggest family history, bleeding duration, and presence of clots as significant risk factors for dysmenorrhea. Appropriate intervention through a change in lifestyle is advised. The barriers to seek medical attention by dysmenorrheic females, they need exploration. Definitely, we have to tackle it at the school level itself. There must be education of the school students. It is important that health education on puberty and menstruation is regarded as inadequate for many young females. This ignorance might adversely affect the medical attention-seeking behavior of dysmenorrheic females. Thank you so much. And I really hope that this drug will be a solution for us doctors and help the patient too, and help all our patients. Thank you, Shield, once more.
Thank you so much, ma'am. Thank you so much for supporting and hoping our product would be really very good for primary dysmenorrhea. Thank you so much for the informative session and very detailed description, ma'am. And ma'am, here in the comment section, we have 2 questions.
Yes.
Shall I read those questions?
Yes, you just read the question.
Yeah. The one question is, what are the current challenges with the treatment of primary dysmenorrhea?
We have to encourage. The whole idea is when the patient, only when she starts suffering from severe pain, then the mother brings the young girl. So yes. What I'm seeing in my practice is that we have to have these sessions with the mother and the adolescent girls. So just like yes. We have had many sessions of PCOS in schools, we gynecologists as doctors, and if we can have sessions in these schools from 8, 9, 7, 8, 9, 10 classes, then we will be along with the mother. So we will be able to give them a correct yes. guidance and sort of give a positive approach to this whole problem. We actually have done it for PCOS, and this will be a wonderful idea to involve and enroll these sessions in schools, and we can do it online. There's no problem. And these type yes, of sessions will definitely be very, very useful. That's my solution.
Yes, ma'am. We can definitely take that one.
Second question.
The next question is the controversy between intake of caffeine. Here they have mentioned caffeine increases pain or not. Does caffeine intake during
No, caffeine I wouldn't, because it is not an anti-prostaglandin, or neither is it improving, neither it is reducing. So I wouldn't much go for it, because this has not been scientifically proved. So caffeine is definitely not the one.
Yes, ma'am. So I guess we only have two questions.
Yes.
So yeah, I think we can close the session now, ma'am. And I really want to thank you again for the session and for your time and for your really good information regarding dysmenorrhea. I really thank you so much on behalf of Shield, ma'am. Thank you so
Thank
much.
you. Thank you, and good evening, and hope you all have a and good night.
Good night, ma'am.
Thank you once again. Good night.